Aneurysm, on the other hand, is defined as the classical criteria for aneurysm. I'm going to tell you the aneurysm is increase in diameter. So increase in diameter by more than 50% of original.
Subscribe and press the bell icon so you never miss an update from PrepLadder.
So hi everyone, let us start with this MCQ session. So today we are going to discuss some important MCQs which are actually taken from the high yield topics of NEET SS entrance exam. So they are important for INI SS also and for NEET SS also. So the first question is from plastic surgery. The question says, a 22-year-old male suffered degloving injury over the middle finger. Following reconstruction procedure was done, identify the flap use. So if you see in this question, there is injury involving this part. Yeah. So the middle finger is actually brutally injured, and this is what is the thenar eminence. Yeah. So we have taken a flap from the thenar eminence. If you see, this is a local reconstruction. Yeah. This is a local reconstruction, but the anatomy of reconstruction is not just adjacent. So you can see the flap has been sutured with the middle finger, and then the skin over this has been accepted. There was a full thickness scar here, and this has taken up this. So what is this? This is actually an interposition flap, also known as interpolation flap. So interpolation and interposition flaps, they're one and the same thing. Actually, they are the local flaps. So let us discuss this. What is the important point about this? So we are talking about the random position flap, and what are the types of random position flaps? Let us try to understand. First of all, random position flaps are limited by their geometry. Why they are limited by their geometry? Because they do not have a very robust blood supply. So always remember, since they are supplied by the dermal subdermal vascular plexus, their site of reconstruction is limited. You can stretch them and you can manipulate them to cover the adjacent defect. Like here, if you have a defect, you can stretch them to cover the immediate defect. We utilize one property of the skin, that skin is elastic, and hence it can be manipulated for the reconstruction. So 2-3 golden points about random position flap is their length and width. It has to be kept within a range. The maximum length is to width ratio that can be taken is 3:1, because if you take the length more than this, or the length is to width ratio is altered, you have to understand that extra part will be what? Devascularized. So random position flaps, we have multiple types. The first is a transposition flap. And in transposition flap, we all understand that flap is transposed over the pivot joints. So it is transposed over the pivot joints to cover the defect. So what are the types of transposition flaps we have? We have a Z-plasty, which is an ideal way of, you can say, scar correction. Yeah, scar contracture correction, because the aim of the Z-plasty is lengthening. Then we have a Limburg flap. Limburg is also known as rhomboid flap. So rhomboid or Limburg flap. This is the first. The second that we have is a rotational flap, which is utilized to reconstruct the rotational defect. So we have rotational flap. The classical example of this is a Webster's flap that we use for what? Lip reconstruction. So there the flap is rotated for the reconstruction. So you can say a Webster's flap for lip reconstruction. Then we have a VY and rectangular advancement flap. So this broad category is actually the advancement flaps. Advancement flaps are the flaps where you advance the flap over the defect. Like take this to be the defect, I'm going to advance this. Like suppose this is the defect, I'm going to separate the skin and I'm going to stretch the skin over this defect. This concept is known as the concept of advancement flap. So based upon the geometry, one very important thing that you all have to understand, that in random position flaps, geometry is defining the name, the mechanism is defining the category. So you are advancing it. So it could be a rectangular advancement, it could be a rectangular advancement, or it could be a VY advancement flap. The next and the last that we have is interpolation or interposition flap. So interpolation or interposition flap, where the local reconstruction is done, but it is in the same region. So you can say these are the special random position flaps which can be used for regional reconstruction. So flap is interposed over the point. So they are used for regional reconstruction. This is very important point. And the classical example I have shown it to you, Thinner flap for fingertip reconstruction. Thinner flap for fingertip reconstruction. This is what. So now let us go to the next MCQ. So we know that the answer for this is interposition flap. Next is identify the lesion shown in the image. Identify the lesion shown in the image. So what it is, try to understand. The lesion that is shown is aortic dissection. So we have something which is known as aortic dissection. Now you all have to understand that aortic dissection, and they have also asked what type of grading it is. So the blood is accumulating in between the layers of the wall. So there is a difference between aneurysm and dissection, and let us see what type it is. Let us see something about this also. This is again very important and very interesting. So when we talk about the concept of aortic dissection, what is important? Let us see. Aortic dissection is defined as accumulation of blood in between layers of artery, and here it is aorta basically. Aneurysm on the other hand is defined as the classical criteria for aneurysm. I'm going to tell you. The aneurysm is increase in diameter. So increase in diameter by more than 50% of original. So by more than 50% of original, if there is increase in diameter, that is what is known as aneurysm. So there's a difference. So when we talk about aneurysm, we all have to understand 2-3 important points about aneurysm. So what type of aneurysm it is, this depends a lot on the things. Let us discuss what are the important things. So first of all, you have to see that the blood is going through this and blood is also entering into this. So this is what is dissection. Now if you see, there is a true lumen here. There's a true lumen here which is compressed by the pseudo lumen. So this is the pseudo, or you can say the false lumen. Now one very important point is, based upon the timing we have a different classification, based upon the flow we have different classification, and based upon the site involved we have a different classification. So let us see the type of aortic dissection. Generally they involve the thoracic aorta. They might extend into the abdominal aorta in certain unfortunate patients. So based upon the chronicity, that means the duration. We may have acute. What is acute? Less than 14 days old. Then we have a new version which is subacute. That is 15 to 60 days old. And then we have chronic, more than 60 days. Do you know why this is very important for us to understand this? Because older the aneurysm, older the dissection, more will be the malperfusion related complications. Then based upon where it is, location, we have a location. We have two standardized classification. Let us talk about those classification. The name of the first is a Stanford. Classification. And when we talk about Stanford classification, we have Stanford A and Stanford B. So we have a lot of classification. Stanford A involves Stanford A involves ascending thoracic aorta. So along, so if it is ascending thoracic aorta, that is what is Stanford A. If it is along the descending thoracic aorta, that is what is known as Stanford B. We also have one more classification which is very famous, and that is Dbe Keys Classification. When we talk about Dbe Keys Classification, what is the version? Let us see. In Dbe Keys Classification, we have Dbe Key 1. It involves both ascending plus descending thoracic aorta. So ascending plus descending thoracic aorta is type 1. What is type 2? Only ascending thoracic aorta. Then what is Dbe Key 3? This involves descending thoracic aorta. Now, when we are talking about descending thoracic aorta, there may be few unfortunate people where the dissection might extend below the level of diaphragm. So 3 is further divided into 3A and 3B. What do you mean by 3A? This is simple. 3A, it involves descending thoracic aorta only. And if you talk about 3B, it involves descending thoracic aorta, and then it extends into the abdominal aorta. So extends into abdominal aorta. They are very important points because this 3B is the one where management or intervention is not available. So let us see this question. If you see, this is the left subclavian and this is the diaphragm. So this is a dissection involving the descending. So this is a type 3A. So Dbe Key 3 is the right answer for this. Let us move to the next question, which is again a very easy question for us. 55-year-old lady visits OPD with the lump in her breast. So she visits the OPD with the lump in her breast. On examination, there is a 5 centimeter lump. Let us see. This is the first clue which is going to hint us about the T in the breast, with multiple mobile lymph nodes in the left axilla. So multiple mobile lymph nodes, this is N1. She has no other complaints in her performance status is 1. That's okay. That's too weak for her, but okay, this is not going to change the answer. There is no sign of distant mets. What will be the stage for this? So the answer is very simple and clear. My purpose was to discuss with you a very important concept on the staging of, or you can say, the TNM of CA breast. When we talk about TNM, the AJCC8 has removed TLCIS. Do you know TLCIS has been removed, and many people say that LCIS is no more considered as a cancer? This is wrong. Why LCIS has been removed? Because LCIS is a slow growing tumor. It's a slow growing tumor. LCIS is a slow growing tumor, and the conversion of LCIS into invasive cancers, it can convert into invasive ductal more than lobular. So the conversion into the invasive ductal or lobular takes a long time. So maybe 15 to 25 years is the time duration that is taken. And the second is only 5 to 15% of them will convert, and more than 2/3 of the patients are perimenopausal. Since they are perimenopausal, by the time some people will develop cancer, the time, you can say, the age will be 70-75 years. And when this is the scenario, you have to understand that the concept of oncosurgery is a surgery done to prolong the life expectancy. And when the patient is on the higher limit of the age, at the age of 75, no one can predict the life expectancy, because at that age the medical comorbidities are going to create that uncertainty. A patient will die maybe later of metastatic organ failures, but quite before that, patient will die of the medical comorbidities, which may culminate into a serious events if the patient undergoes surgery. So No, because it's a slow growing, because only a few people are involved. No, now surgery is not an active treatment option for them. Thus, TLCIS has been removed. So we have T Pagets, we have T Pagets, we have T DCIS, we have T1 which is less than equal to 2 centimeter tumor size, and then we have T2 which defines more than 2 up to 5 centimeter, like in this question. T3 is more than 5 centimeter. T4 is any size. T4 is any size, and the most important fact is any size with T4A into chest wall. Now when we are talking about chest wall, one very important point that we all have to understand, that chest wall involvement doesn't include the pectoralis major. So P major, this is not included in this P major involvement. Then we have T4B. What is T4B? This is into skin. Now when we are talking about into the skin, what it includes? So it includes only 3 important things. What is that? Edema, or edema might be referred as PUD orange. So edema or PUD orange, point number 1. The second very important thing, so edema or PUD orange. The second very important thing that we all have to understand is satellite nodules. So satellite nodules, or you can say, or what else? The word ulcer. If these 3 words are not given, we cannot consider it as for T4B. Then we have T4C. This is 4A plus 4B. And what is that? That means skin and the chest wall both are involved. And then we have T4D. What is T4D? Inflammatory cancer. Inflammatory cancer. This is what. Then if you see the N part, N1 is defined as mobile level 1, level 2 axillary lymph nodes. So mobile level 1, level 2 axillary lymph nodes. N2 is further divided into N2A and N2B. When we talk about N2A, N2B, what does that mean? The very same mobile lymph nodes, now they are going to become what? Fixed. So fixed level 1, level 2 axillary lymph nodes, point number 1, or ipsilateral internal memory lymph nodes. Ipsilateral internal memory lymph nodes. N3 is further divided into N3A. What is N3A, students? Ipsilateral level 3, or you can say the apical group of lymph nodes, or better to say infraclavicular lymph nodes. Then we have N3B. What is that? Presence of axillary lymph nodes. So if axillary lymph nodes are also present, and maybe on scan the internal memory lymph nodes, so the internal memory lymph nodes are also there, that's N3B. And what is N3C? Presence of ipsilateral supraclavicular lymph nodes. Always remember, contralateral is metastasis, so supraclavicular lymph nodes. And you know, N1 or M1 is metastasis, M0 is no mets. So if you see, the size is 5 centimeter, and hence this is T2. There are mobile axillary lymph nodes, so N1. So it is T2, N1, M0 is a very simple answer. So identify the grade of VUR shown in the image. So if you see this question, this is a question on Psycho-Ureteric Reflux. And let us quickly discuss the concept and the basics and grading also. So when we are talking about VUR, what does that mean? Vesico-ureteric reflux. And vesico-ureteric reflux is defined as the upward reflux of urine into the upper urinary tract. So the reflux of urine from the bladder into upper urinary tract. So into ureter or into the kidney. This is what is the simplest way of understanding it. Now, when we are talking about the staging, this is very, very, very simple and straightforward. So stage 1 or grade 1. Grade 1 is into ureters. So if it is going into the ureter only, that is grade 1. When you talk about grade 2, This is into ureter plus the kidney. But there is no dilatation. Grade 3, it is grade 2 plus blunting, or you can say ballooning of calyces, Now this is what is ballooning of calyces. Let us try to understand. So if you see the urogenital system, this is something like this. So if it is managing to enter into the ureter, that is 1, up to the kidney 2. Now can you see the USP of this calyces is their cupping. So if there is loss of cupping, this is what is known as ballooning of the calyces. So can you see, this is what is the ballooning of calyces. So here, so you have lost the calyces. This is because of the reflux. There is fullness and loss of calyceal, you can say cupping. Then you can also say blunting of calyces, ballooning of calyces, or blunting of calyces. Yeah. Now what is grade 4? Grade 4 is grade 3 plus effacement of the calyces, plus calyceal effacement. So effacement of calyces, and along with that plus moderate dilatation of the calyx. So if you see this, what is moderate dilatation of ureter plus calyceal system of the kidney? So let us see what it is going to be like. This is something like this. So the calyces have not only been, you can say, not only ballooned up, but they have effaced also. What is type 5? This is mega, or you can say grossly distorted system. So grossly distorted pelvic calyceal system. So grossly distorted pelvic calyceal system. This is what is type 4, and this is very important. Let us see more important things. This is type 5. Sorry. Let us see. This is type 5. So if we go to the question, and see, so there is ballooning of the calyces. And this is what is a type 3, a standard type 3. Now 2-3 more important points about VUR. What is the concept of VUR and why VUR happens? So VUR is of two types. Either it is a primary VUR. What is a primary VUR? A primary VUR is a VUR where the pelvic calyceal system is, or you can say it's a VUR due to the intrinsic defect of the kidney, or intrinsic defect of the urogenital system, not because of a secondary obstruction. The secondary VUR is associated with distal obstruction. So it is associated with obstruction to flow. And here the defect is in the ureteric system. So what is that? This is associated with defective intramural ureter. So what is this intramural ureteric length is to width? Let me tell you this concept. So always try to understand, if this is the bladder, this is very important point for all, that this is the ureter opening into at the level of trigone. This length is very important. This length is to width. If this length is to width is more than 5:1, this is absolutely normal. Less than 5:1, this is, now when the patient is voiding urine, the bladder contracts, and when it contracts, it will constrict the ureter, and hence it prevents the reflux. So if it is less than 5:1, this is going to cause reflux. This is what is very important. You know that investigation of choice is MCU, micturating cystourethrogram and voiding cystourethrogram is very important investigation to prove this. Let us move to the next question. So there is a testicular pathology shown in the image. and all except are true for this. So when we talk about this testicular pathology, can you see the scaly, firm trabecular lesion? Trabecular lesion. Okay, so scaly, firm trabecular lesion. What is this suggestive of? This is suggestive of seminoma. This is suggestive of seminoma. So when we are talking about this, this is what is very important. Just by seeing the pathology, there's a testicular mass which is scaly, spongy, trabeculated, and this is suggestive of seminoma. Now, when we are talking about few important points, let us see ITGN, let us talk about CD117 and everything. So, what are the important points about seminoma testis? Now, seminoma, it is of two types. What are the two types of seminoma? Or before that, let us consider the concept of germ cell tumor. So, testicular tumors are of two types. One is the germ cell tumor and one is the non-germ cell tumor. When we talk about the non-germ cell tumor, we have others like Leydig cell tumor. We have Leydig cell, which is Leydig cell tumor. It is the most common non-germ cell tumor. Then we have Sertoli cell tumors. Then we have granulosa cell tumor, and then we have gonadoblastoma. When we talk about the germ cell tumors, we have the seminoma, which is further defined into two broad categories: a classic seminoma and a spermatocytic. We also had one more variety of seminoma, that was anaplastic, but this of late anaplastic is no more taken into consideration. Then we have non-seminoma. We have embryonal cell cancer. We have choriocarcinoma. We have yolk sac tumor. And we have teratomas. Now let us talk about some important points about them. So when we are talking about the concept of ITGN, what is ITGN? Intratubular germ cell neoplasia. So you have to understand that intratubular germ cell neoplasm, this is actually the carcinoma in situ from which all the tumors are arising. So this is equal to carcinoma in situ of testis, and important is it is precursor of all the testicular tumors. So it is a precursor of all testicular tumors. The only exception to this is the spermatocytic version of seminoma. So except spermatocytic seminoma. Now let us discuss one or more important points, that this ITGN is associated with extra copy of 12p. So this is associated with extra copy of chromosome number 12. Let us see some more important points. When we are talking about the management, I'm directly going to the management part. It's very important to understand when you talk about the treatment. Whenever you have a suspicion of testicular tumor, the first thing that we all do is a high inguinal radical orchidectomy. Now, when you are doing high inguinal radical orchidectomy, this is going to tell you that either this is a seminoma tumor, or this could be a non-seminomatous germ cell tumor. If it is seminoma, then you will have to understand what stage does it belong to. If it is stage 1, then only thing that you require is a brachytherapy. If it is stage 2 or if it is stage 3, you require chemotherapy plus radiotherapy. When we talk about chemotherapy, we have 3 cycles of bleomycin, etoposite, cisplatin. Also 15 to 25 grays, 15 to 25 grays over 6 weeks, and that too in weekly divided doses, Now when you are talking about non-seminomatous germ cell tumor, but before that, one very very important thing which I have also asked in the question, that since seminoma they spread by hematogenous route, yes, therefore there is no call of retroperitoneal lymph node dissection. So there is no role of retroperitoneal lymph node dissection. This is very 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 important point. If you talk about the non-seminomatous germ cell tumor, stage 1, you always go for chemo plus radiotherapy. Stage 2, what is the management, students? You will have to go for induction chemotherapy. Why induction chemotherapy? Based upon this fact that testicular tumors are highly chemosensitive, so a high dose chemotherapy is given, and after this is same 3 into BEP. After this, you will do a CCT abdomen, and why you do a CCT abdomen? To check out the retroperitoneal lymph nodes. If they are present, that means para-aortic lymph nodes are present, then you will go for retroperitoneal lymph node dissection, and followed by them again chemotherapy plus radiotherapy. If retroperitoneal lymph nodes are not present, then what to do? You will just simply go for radiotherapy. If you talk about stage 3, you will have to go for retroperitoneal lymph node dissection plus chemo and plus radiotherapy. So let us see this question. It arises from ITGN, true. CD117 positive, yes, they are CD117 positive and CD30 negative. Also they are positive for alpha fetoprotein, no. They are negative for alpha fetoprotein, positive for lactate dehydrogenase, positive for placental alkaline phosphatase. In 10% cases, positive for beta HCG also. Requires retroperitoneal, this is false, and scalene tubercular, this is true. So now we go to the next question. Identify the endoscopic bariatric surgery shown in this. So basically, there's a pic. You can see this pic. What do you think it is? What it is? It's a long sleeve. If you see, it's a long impermeable sleeve. And then this is one inlet. So actually, this is the gastric inlet. Which is made up of nickel and titanium alloy. And this is actually going to fix in the antrum part from where the food will enter into this, and then food will be directly delivered out. So this is basically an endoscopic malabsorptive technique. Endoscopic malabsorptive procedure. And what is this endoscopic malabsorptive procedure known as? This is known as endo barrier. Yeah. So this is what is endo barrier. Let us talk about this concept. Let us see this thing. This is very simple and straightforward. Let us see. When we talk about the bariatric surgery, nowadays there is a boom of, you can say, endoscopic bariatric procedures also. In this, we have the laparoscopic procedures, and now we have endoscopic procedures. Actually, laparoscopic procedures are also endoscopic procedures, but they are the second space endoscopy, and this is the natural, you can say, natural cavity endoscopy that we are using. So laparoscopic procedures, we basically have a restrictive category of surgery. We have a restrictive plus malabsorptive, and we have malabsorptive category of surgeries. Like we have laparoscopic sleeve gastrectomy. We have LAGB. Nowadays we are not doing LAGB. What we are doing, LSG, laparoscopic sleeve gastrectomy with gastric banding. And this is seen to have a better outcome. So these three procedures are now registered restrictive procedures. Then what are the malabsorptive and what are the restrictive plus malabsorptive? Laparoscopic Roux-en-Y gastric bypass and mini gastric bypass. So mini gastric bypass and laparoscopic gastric bypass, they are ruling the world now. And then we have malabsorptive, which is least performed nowadays because of the complications that we have. So we have biliopancreatic diversion and we have duodenal switch. We have duodenal switch and biliopancreatic diversion. Now when we talk about the endoscopic procedures, the first is we have toga. What is toga? Transoral gastroplasty. Then we have pose. This is primary obesity surgery endoluminal. So primary obesity surgery endoluminal. Then we have rows. So we have pose, we have rows. Do you know what is rows? It is it's a endoscopic reconstructive, you can say, bariatric procedure for the patients who have undergone the sleeve gastrectomy in past. So they have undergone sleeve gastrectomy and now the stomach has again, you can say, dilated and the patients are showing weight gain. So for them we have, so this is restorative obesity surgery endoluminal. We have endokinch. There is one more procedure, endokinch. So all these procedures that you are seeing, procedure 1, 2, 3 and 4. So 1, 2, 3 and 4, they are EGP based. EGP, what is EGP? Endoscopic gastric plication. So endoscopic gastric plication based procedures, gastric plication based restrictive surgeries. Now what is this concept of gastric plication based restrictive surgeries? Let us see. They are very, very, very simple. If this is the stomach, we have some auto suturing device. Which is going to suck in the gastric, you can say, wall, and then it is going to put the T-shaped sutures or H-shaped sutures. Based upon where we are doing, it is defined as various names. So if you see the effective space in the stomach, only this much is left. So bachcho, if you see toga is done along the lesser curvature. Pose is done along the fundus and the greater curvature. Rows, this is done post sleeve gastrectomy. So post sleeve gastrectomy, if you do the pose, that is what is known as rows. And then endokinch, this is along the lesser curvature. So these are the classical things. Then we also have endoscopic intragastric balloons. So endoscopic intragastric balloons. What do you mean by endoscopic intragastric balloons? This is Orbera. And this is very, 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 very important. So what we do, we inflate and place a balloon. This is a silicon balloon which is having 600 ml volume, and it can be kept up to 6 months. So if you see, it effectively reduces the space available in the stomach. And the last is the endo barrier. When we talk about endo barrier, I have already shown you the image of this. This is endoscopic malabsorptive procedures where actually you are placing an impermeable sheath. So what is this impermeable sheath all about? It has a crown which fixes it to this place, and now this is the sheath. So whatever food that you are going to eat is going to be, yes, so this is the sheath. Imagine this is the sheath. Okay, so the food that you are going to eat is directly going into this sheath and delivered somewhere here in the jejunum. So if you see carefully, for this long time there is no bile and pancreatic juice available, and without bile and pancreatic juice there will be no assimilation. So you have actually wasted the entire duodenum and jejunum, and this is what is known as endo barrier. We have also, so this is up to the jejunum part. We have a valen TX, which is a long segment. So we have valen TX, we have endo barrier. So let us see this question. This is an endo barrier in front of you, and now you know the others also. So now, next question is, identify the type of hernia and answer the following with respect to it. All except are true. So if we see what hernia are we looking at, what is this space? This is a classical case of Spigelian's hernia, and we all have to understand that Spigelian's hernia is a defect via Spigelian's fascia. So where do we have the Spigelian's fascia? Let us see everything and then we'll revert back to this question. So if we talk about the concept of Spigelian's hernia, let us see this. Okay. So when we have Spigelian's hernia, where is it? This is a herniation via Spigelian fascia. And where is Spigelian's fascia? This is a fascia between transversus abdominis and rectus and the rectus. Now try to understand, if we take this as the rectus, and the last muscular layer of the abdomen is the transversus abdominis. So this is the last muscle layer, and you know that below the level of arcuate line, we don't have anything as posterior rectus. So let us take this to be the arcuate line. Yeah. So this fascia, this thinned out fascia, this is what is known as the Spigelian's fascia. Now the problem is, where do we see the potential defect? Now at the point of intersection of linea semilunaris with the linea semicircularis. So if you see, I'll drawing into the different color. So this is linea semilunaris, and here we have linea semicircularis. So can you appreciate a potential defect below the level of umbilicus? So this is where the potential defect is, and this is, where is this defect? This is below the level of umbilicus at intersection of linea semilunaris with linea semicircularis, and this is very important. So one thing is clear, that more than 80 to 90% of them, they are what? Infraumbilical. I'll give you one more thing to understand. If you see this as the rectus, if you take this as the rectus, yeah. Now let us talk about the contributors to rectus sheath. So we have this as external oblique, and you know external oblique will form aponeurosis, which will directly strengthen the anterior rectus. Then we have the internal oblique. Internal oblique will give one support to the anterior rectus and one support to the posterior rectus. And then we have transversus abdominis, where transversus abdominis is entirely going to contribute to the posterior rectus. So this is the rectus sheath. Let us talk about the rectus and its sheath. So this is above the level of umbilicus. Now let us see the similar scenario below the level of umbilicus. So this is the rectus muscle. This is the external oblique. Let us take this to be the very same external oblique, and it is contributing to the anterior rectus as expected. So this is anterior rectus, anterior. Then we have transversus abdominis and internal oblique. So you know that internal oblique is also strengthening the anterior, and even the transversus abdominis, this is also strengthening the anterior. In terms of the posterior rectus, you are left with the fascia transversalis and the peritoneum. Can you see that below the umbilicus there is a potential defect? What is this potential defect? This is the potential defect, and therefore the herniation of omentum and fat can happen. But you don't expect that bowel will go. This is not a very big space. One very important thing, that below the umbilicus I can understand this is the fact, but the anterior rectus below the umbilicus is more reinforced and therefore you don't get to see any swelling. So important, very important point is they are true intraparietal hernias. They are true intraparietal hernias. So this is very, 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 very important. True intraparietal hernias. Now let us see the point. Let us see the question. Mostly infraumbilical, true. Requires surgical repair because of the strangulation and incarceration. Yes, true. MRI is the best investigation for evaluation of abdominal wall. Basically soft tissue evaluation. Palpable expansile mass seldom seen. So B is the answer for this question. So now let us go to the next question, students. With respect to the upper pole of the thyroid, identify the structure labeled as A and B and identify the nerve in relation. So what type of nerve relation is this? I have asked in the question. What are the structures? If you talk about the structures which are labeled as A, this is the superior thyroid pedicle. So this is the superior thyroid pedicle that we have. And if we talk about this nerve, the nerve we are talking is external branch of superior laryngeal nerve. So external branch of superior laryngeal nerve. This is what. Now what I want to discuss in this question is a very important nerve relation. Now let us talk about this nerve relation. Let us see. Whenever we talk about the superior thyroid pole, superior pole of the thyroid, and let us take this to be the artery, superior thyroid artery, and this to be the superior thyroid vein. The external branch of superior laryngeal nerve is coursing some way along the superior thyroid pedicle, and then it takes a U-turn and goes into the larynx. So this is external branch of superior laryngeal nerve. Now students, this relation of this branch with the superior thyroid pedicle. So this is, let us take this to be superior thyroid pedicle and let us take this to be nerve. This relation is very important and this relation depends upon the gap. So students, this gap is very, 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 very interesting. If the gap is more than 1, if the gap between the superior thyroid pedicle and the nerve is more than 1, then this is known as type 1 arrangement. If the gap is less than 1, then that is known as type 2 arrangement. So that means if the nerve is too close to the pedicle, that is type 2. Now type 2 is further divided into 2A and 2B. What is 2A and what is 2B? 2A is defined when the nerve is less than 1 centimeter. So nerve is within less than 1 centimeter of pedicle, but it is above the pedicle. Like suppose, let us see, this is the scenario, this is the superior thyroid pedicle, and let us take this to be nerve. Yeah, if this is less than 1, then that is known as a type 2A configuration. What is type 2? This is nerve is less than 1 centimeter of pedicle, and remember it is crossing from below. Now this is why and what makes the nerve very, you can say, interesting. So crossing from below, this is what is. Let us see this in an image. So if this is the superior thyroid pedicle, if the nerve is going like this, this is what is the most dangerous configuration also. This classification is what is known as Cernia's classification. This is a very famous classification which is known as Cernia's classification. And you know, we have a lot of triangles also for identification of the nerve. Yeah. So let us talk about one interesting triangle, and that triangle is a Joll's triangle. What is a Joll's triangle? It's a triangle to identify the recurrent laryngeal nerve. So if you talk about, this is the superior thyroid pedicle, this is the midline. So we have the midline, we have the superior thyroid pedicle, and when we retract the strap muscles, so they acquire a horizontal. So this is retracted strap muscles. So retracted strap muscles, the superior thyroid pedicle. This is superior thyroid pedicle, and here this is a triangle which is known as a Jol's triangle. And remember, the superior laryngeal nerve is always so external branch of superior laryngeal nerve is always there in this triangle. There are some other triangles also that you might have heard. We have triangle of Biars, we have Lore's triangle, we have Lore's triangle. These two triangles are for recurrent laryngeal nerve. I'll quickly share what are they. If you talk about Lore's triangle, this is the common carotid artery. Here you have trachea. This is the trachea. So common carotid artery, the trachea, and always remember above, this is the inferior thyroid artery. So when we talk about inferior thyroid artery, trachea and the common carotid artery, the triangle which is created here, this is what is known as Lore's triangle. Lore's triangle is a very important triangle, and I actually personally prefer Lore's over Biars. Now what is a Biars triangle? Let us try to understand. So if this is the thyroid, if this is the common carotid, always remember the inferior thyroid artery takes a 90-degree turn around the scalenus medius and goes behind the common carotid, and then it starts to give the branches to parathyroids at the inferior pole. Now this is a triangle which is created by, here the recurrent laryngeal nerve is going. So a triangle created between the inferior thyroid artery, the common carotid and the recurrent laryngeal nerve. This is what is. In Lore's triangle, the recurrent laryngeal nerve is a content. In the Biars triangle, it is the border. So this is all about this question. Let us move to the next question, but before that, let us see the answer. If you see in this case, the nerve is going from below, and hence the answer is, this is type 2B. So this name, remember the name of this classification, this is a Cernias classification. Let us go to the next question. If we see this question, this is a question on SEEP. A patient with chronic venous insufficiency presents with pigmentation and ulceration over the limb. Now there is pigmentation and ulceration over the limb. The patient underwent a Doppler scan which showed echogenic debris in the popliteal vein with some below knee incompetent perforators. He has a history of DVT 6 months back, and this is the image, and they are asking the SEEP. Now when we talk about SEEP, let us have a brief idea, and let us have a quick revision of what is SEEP, and then we'll go to this question and solve it out. Now SEEP is a grading system. SEEP is a grading system for chronic venous insufficiency. So it's a grading for chronic venous insufficiency. And when we are talking about chronic venous insufficiency, we have to see a lot of things here. Let us see. C stands for the clinical presentation. The clinical presentation. And when we talk about the clinical presentation, what are the important things that we have? C1 includes the telangiectasias. C1 includes the telangiectasias and also the reticular veins. Then we have C2. C2 is, we have something which is known as varicose vein. So C1 is telangiectasias and C2 is varicose vein. C2A is if the patient is asymptomatic. C2S means if the patient is symptomatic, and C2R if we are dealing with a recurrent. So if it is recurrent, this is C1, C2. Next is, we talk about C3. What is C3, students? It's a concept of pigmentation. C3 is edema. C4 is further divided into C4A, which is pigmentation, C4B, which is lipodermatosclerosis. Students, you know, lipodermatosclerosis is fibrosis over the Gator zone. And then we have 4C, which is corona phlebectasia. When we talk about C5, it is defined as a healed ulcer, and C6 is defined as a non-healing ulcer. Now, what do we mean by E? E stands for etiology, so it can be EC if it is by birth, E primary if there is no associated cause, or it can be ES, that is secondary to some etiology. Suppose if it is occurring after DVT, so it will be ES because it's secondary to DVT. Then we have A stands for anatomy, and when we talk about anatomy, we have AS, that is superficial venous system, superficial venous system. AD we have for deep venous system, and then we have AP, that is for the perforators, So AS, AD and AP, this is what is very important. And then we stand for pathophysiology, P. So if it is associated with debris, so this will be what? Obstructive. If it is associated with what? A reflux, a faulty valve, so it will be PR, that is reflux. So let us quickly see how we will solve this MCQ. A patient with chronic venous insufficiency presents with pigmentation. So pigmentation means what? C4A at least. And ulceration over the lower limb. Ulceration means what, students? It will be C5 or C6, but if we see this is an active ulcer, so C6. The patient underwent a Doppler scan which showed echogenic debris. Debris is there, that means it will be obstructive in pathology. In the left popliteal vein is a part of deep venous system, so A deep, with some below knee incompetent perforators. So perforators are also gone, and if they are incompetent, there will be a component of reflux. The patient underwent a treatment for DVT 6 months back, so the etiopathogenesis is secondary. So the answer will be C4A plus 6. Then the etiology is secondary. The anatomy is deep venous system plus perforator, and pathophysiology is both O plus R. So if we see the answer that we have C6 plus 4A, either ES, AD plus P and PO plus R, this is what is the answer. D is the best available answer here, and this is what is very, very, very important. Now let us see this question. What is this question? Identify the intervention procedure done for the patients of chronic venous insufficiency with incompetent perforators. So students, if we talk about incompetent perforators, what are the 3 standard protocols? The treatment for incompetent perforators. The treatment for perforators, we have 3 things. Either we can go for stab avulsion, or we can go for SEPS, or we can go for Trivex. Let us see what they are. But so in this case, if you see, there is a port. There is a 10 mm port through which camera has gone inside. So the camera has gone inside via this port, and this is an instrument. Let us have a brief discussion, and then we'll come back to this, what we are doing there. So the procedure which is shown here is SEPS. What do you mean by SEPS? SEPS stands for subfacial endoscopic perforator surgery. So subfacial endoscopic perforator surgery. Now this is very, very, very simple and a novel approach of the perforators. So what we are going to do, we utilize one property, that there is something which is known as superficial venous system, there is something which is known as deep venous system, and in the subfascial level we have multiple vessels which are known as perforators. So 7.5 centimeter lateral to tibial tuberosity, you establish one 10 mm port, and via this port your telescope has gone inside. You establish 5 centimeters lateral, you establish one more 5 mm port, and via this you can use a 5 mm, you can use a 10 mm. Via this, first your clip applicators go and you just clip it, and then you take out this clip applicator and you insert a scissor, and you simply divide them. And this is what is the cell management of perforator. So this is subfascial endoscopic perforator surgery. Now students, what is Trivex? Trivex is also just like this. You must have seen that movie Bahubali. In that Bahubali, there was a character Ballal Dev, and I was just fascinated by seeing his chariot. You must have seen that chariot, and that chariot was always, this was a blade, this was always rotating, yeah. This blade was always rotating, and anyone who came in front was divided into half up, half down. Yeah. So remember, what is Trivex all about? Trivex, we utilize this property that in the subfacial space there are perforators, and therefore there is powered phlebectomy. You can say powered phlebectomy, or you can also say motorized phlebectomy. Motorized phlebectomy. So this is a miniature motor with an ultra fine blade mounted on it, and what we do under the USG guidance, just like we are doing in SEPS, but here you are not going to create any port. Under the USG guidance, you will take this motor and start the blade at the place of the perforators, and like this. Similarly, like you did in, you saw it in Bahubali. Anything which is coming in front, yes, you chop it off. And then you put up what? You can say crepe bandage. So this is how you stop the perforators from bleeding, and this technique is known as motorized phlebectomy or Trivex. The next is the stab avulsion. In the stab avulsion, you are not doing anything. You are just utilizing the Desi funda. You are taking out the vessel. You are bringing a stab. Yes, you are bringing the blade in number 11, and you are just simply dividing it. Now try to understand, when you divide it, the vessel will be bleeding like this. Yeah, vessel will be bleeding like this, because you have just divided the perforator. What you do, you take a deep bite, and with one single bite you close it. This is the easiest and the quickest way, but the drawback is for every perforator you have to make one stab. So 10 incompetent perforator, 10 stabs, and hence cost misses. So this is what is known as stab avulsion. Remember, normally what we do, we ligate the vessel on both the sides and then divide. We are not doing in this. We are using stab blade number 11, and then we are just dividing it. This is what. So let us go to this question, and this is where the SEPS is, subfacial endoscopic perforator. EVLA stands for endovascular laser ablation. This is for varicose vein, not for perforator. So endovascular laser ablation. I've discussed Trivex, and I have Trendelenburg surgery, simply the ligation of saphenofemoral or saphenopopliteal junction plus minus stripping of the vein. We always do above knee stripping so that the nerve is spared. So the answer for this is SEPS. So I hope you enjoyed this session with me, and all the best for your preparation.